All right, so here we're going to discuss a series of research designs that are known as single subject research. After this PowerPoint, you should be able to understand how single subject research is conducted, particularly the phases of this type of research. You'll also be able to describe the different types of single subject research, as well as know how we analyze single subject data. So, as the name implies, in a single subject design, we have either a single research participant or, in some cases, a few participants. But this is very different from large group studies in which we might have something like 30 or 60 or hundreds of research participants assigned to treatment groups or control groups. Single subject designs are considered experimental designs because they have a large measure of control built in. One element of this control is that the participant will participate in all of the conditions. Those conditions are likely to be a treatment condition as well as a no treatment condition, but it could also include two treatment groups. We collect data for our participant or participants during all phases of the study. This means that once we have identified the client's goal, we collect data for that goal during the entire length of our study. The data we collect on our client's goals is known as the dependent variable, or the DV. We'll look at more examples of specific single subject designs to give you a better idea of what this means. This is a graphic of some of the phases in a single subject research design. Often we will have a no treatment condition and a treatment condition. In the no treatment condition, we are simply baselining the client's performance on their goals without doing any treatment. We then plot each data point on a graph of the client's performance. Eventually, we will move on to a treatment phase, and we'll continue to take data on the client's goals, which we will call probes. So you can think of single subject designs as being a series of baselines and probes collected over time and plotted on a graph. One of the simplest forms of this kind of design is what we would call an A-B design. The first A in a graph, like this, represents the baseline phase, in which you're not doing therapy but are still collecting data. On this graph, on the x-axis, we see that the measure of time is days, and on the y-axis is the frequency of disruptions. So we're plotting frequency of disruptions, and that is our dependent variable. So maybe these researchers are conducting an experiment to see if their treatment for a child with autism results in less disruptive behavior in the classroom. You can see that in the A phase, or the baseline phase, the researchers took data over 3 days, and the number of disruptive behaviors was quite high. Once they had established a clear trend in their baseline data, the researchers implemented their treatment in the B phase. You can see that they've plotted the data for each day that they probed for the dependent variable, and it looks like the frequency of disruptive behaviors did decrease over time. Now, the problem with this design is that we don't really know if the frequency of behaviors decreased because of the researcher's treatment or for some other reason. For example, what if the parents have promised the child a new bike if he behaves in school? Or what if the child started a new medication that the researchers were unaware of, and it helped to calm some of those disruptive behaviors? So what we do if we really want to show cause and effect between our treatment and the client's progress towards their goal is to withdraw treatment after that first B phase. If we withdraw treatment and the client's behaviors go back to where they were at baseline before we gave them treatment, we can be more sure that it was our treatment that influenced their progress. So withdrawing treatment in a single subject design is all about experimental control. So here we have an example of a withdrawal design known as an ABA design. This is the same graph as the previous AB graph, except we've added another A phase. So typically we'd call the first A phase the baseline phase, and the second A phase would be known as the withdrawal phase. But you're still taking baseline data in all phases of A, meaning that you're not administering treatment, you're just collecting data on the dependent variable. You can see just by looking at the graph that the frequency of disruptions started off pretty high, then the researchers implemented the treatment and the disruptions decreased, and then when they withdrew treatment in the second A phase, or we could call that the withdrawal phase, the frequency of those disruptions were trending upwards to about the level of that initial baseline in the first A phase. So this makes it pretty clear that no matter what was going on with this kid in terms of parental incentives or medications, that it was the treatment that made the difference in terms of his disruptive behaviors being reduced. Here's another example, and in this graph, the x-axis is the measurement in minutes, and the y-axis is what they're calling number of stutterings, which is a funny way to say disfluencies, but anyway. You can see even though the A, B, and A labels aren't on the graph, that there are 3 phases, and in the first phase, the A baseline phase, the number of disfluencies were pretty high. Then with treatment in the second phase, or the B phase, the disfluencies decreased. And then when treatment was withdrawn in the second A phase, known as the withdrawal phase, the number of disfluencies increased. So we see that the line is trending back towards baseline, which was in that first A phase. So this is another classic ABA graph, which would show that treatment was effective in this case. Now we can get even more sophisticated with these withdrawal designs because it may have occurred to some of you that it doesn't seem particularly desirable to introduce treatment to our clients only to take it away. And further, it seems like there would be even more evidence to support our claims that treatment worked if we reintroduce treatment in a second B phase. So that is exactly what we do if we have the time, and in some cases the money, if you're running a larger scale research project. You can see on this graph that rate is the dependent variable, and it is measured across time. So this is a very generic graph, but I think in this case, increased rate is the target. And you can see that in the first A phase, baseline showed that the rate was very slow. And then when treatment was introduced, the rate improved. In the second A phase, treatment was withdrawn, and you have a return to baseline or almost near baseline. And then when treatment was reinstated in the second B phase, the rate increased once again. So we can see from this rather perfect graph that the reinstatement of treatment after the withdrawal phase provides even more control, as well as leaving the client in a more positive state because they're left on a high note, so to speak, in terms of their goals. So if you are designing a treatment study and you're going to use a withdrawal design, the AB design is one of the best. Now let's take a look at the BAB design. This is still a withdrawal design. However, you'll notice from this graph that it starts with a treatment phase before withdrawing treatment and then reinstating treatment in a second B phase. This is a great design to use when you have limited time or when it doesn't seem ethical to wait to begin treatment. So let's say you have a child on your caseload who moved into your district and you've only got 4 weeks with them until it's the end of the school year. Or you have a client who had a stroke and treatment should begin immediately. Now, in both of these cases, were you to conduct a research study with these clients, it wouldn't necessarily be ethical to put these clients in baseline for a number of days before beginning treatment. So by starting with treatment and then withdrawing before going back to treatment, you can make sure that your treatment is working while still getting started right away. And I actually took this approach with a student who was in this class, and she wanted to actually carry out a single subject study with a client on her caseload in our clinic. And she was already doing therapy with her client at that point, so we simply withdrew treatment and then reinstated it, and we had a nice BAB design. So in terms of withdrawal designs, there are some times when it is very appropriate to use these designs, as in some of the cases I've presented here, but in other cases it's not appropriate. Now, certainly if there are ethical considerations, such as perhaps in dysphagia studies, where a no treatment condition might mean an unrestricted diet, we shouldn't do these types of designs. But when we need to demonstrate a clear relationship between what we are doing clinically and how the client is responding, withdrawal designs can be very simple and very effective. We also have to make sure that we don't use withdrawal designs if we're teaching some strategies or techniques that the client sort of internalizes or generalizes right away, because if they grasp the concept immediately, they'll apply it also in withdrawal conditions, and we won't be able to demonstrate that it was the technique that made a difference. So we do need to be selective in terms of what therapy goals might be more appropriate for a withdrawal design. All right, so moving on from withdrawal designs, we can talk about multiple baseline designs. These designs are very helpful when you have 2 or more subjects, or 2 or more behaviors, or 2 or more settings that you are interested in examining. So in the graphs on your screen, the print is a little bit small, but the first graph along the y-axis says behavior 1, and there is an A and a B phase. The second graph says behavior 2, and there is another A and B phase. So there is one treatment that is going to be applied to 2 behaviors in this case. Now you can see that these are simply A-B graphs stacked on top of each other. But note that the A phase for behavior 2 is much longer than that of behavior 1. And this is where the power of multiple baselines comes in. We don't start treatment at the same time for both behaviors. We start by baselining both behaviors, but once we have a stable baseline, we implement treatment for behavior 1 only. But we keep on baselining the second behavior. We do this until the first behavior shows a treatment effect, and only then do we implement the treatment for the second behavior. Keep in mind that instead of behaviors, it could be 2 or more participants or 2 or more settings, such as morning versus afternoon, or school versus home, and so forth. So here is an example, which is looking at the effects of feedback on the correct production of the P and S sounds. So these researchers started baselining for both sounds at the same time, and when they had a stable baseline, that is, in this case, the child couldn't produce the P or S sounds correctly at all, they began treatment of P. And you can see by the dotted line that even while they were treating the P sound, they were still collecting baseline data for the S sound. Once it was pretty clear that the treatment was working for the P sound, they then implemented treatment for S. Now you can see the power of this design because you can be sure that it really was the treatment that influenced the change in the behavior. If you simply looked at the effects of the treatment on P and you only did an A-B graph, that wouldn't have much power at all because there's not a lot of control. So did the child just mature a bit and that's why he started to improve? Or did the parents start working on the P sound at home? We wouldn't know. But because the S sound didn't improve until treatment was administered, we can tell that it must be the treatment that has the effect on this child's sound production. So multiple baselines are very helpful when you want to examine multiple targets or settings or participants, but you want the convenience of a simple A-B design. Now, one issue that can crop up in multiple baseline designs is the issue of covariance. Covariance happens when you get A-B graphs that show that the treatment is having an effect on all of your behaviors or participants or settings at one time. This messes up your ability to say that the treatment is effective because you can't know for sure that it was your treatment that made the difference. You've lost experimental control. So one of the ways we get around this is to pick our dependent variables very carefully. In our example of the P and S sounds, the researchers probably chose those targets very carefully because if the sounds were too alike, such as fricatives like S and F, it is more likely that the treatment effect would generalize to both behaviors. So they used a fricative and a stop, both of which the child needed to work on in therapy, but which were different enough that there was little chance of covariance. So there is one more type of design that we'll talk about in a separate lecture, but for now I want to emphasize that we very often don't use statistics to analyze the results of single subject research, especially not in small-scale clinical research, such as clinicians might use in their own practices. We just plot out our data on relatively simple graphs, and we can see if there is a treatment effect. So we're looking to see if there is a fairly large change from one condition to another, and if there is, we're pretty satisfied that our treatment was successful for our individual client or clients. This is very different than group research studies where the performance of all participants is averaged to see if there is a significant effect for clients in general. So to reiterate, simply look at the graph to decide if there is an improvement for your client rather than using statistics to determine if there is a significant treatment effect. Okay, so before we end, I wanted to answer some frequently asked questions. First is the issue of picking a goal to measure for your client. That is, what should your dependent variable be? If you've got a client and they're already performing pretty highly on a given goal, you're not going to have much room on your graph to demonstrate that it's your treatment that is causing a change in the behavior. So if they're at more than, say, 70% in terms of achieving their goal, you may need to find a different target, at least for the purposes of a single subject study. Of course, we want our clients to be better than 70%, but just from a control standpoint, it will be difficult to demonstrate that it's our treatment that is causing further improvement. Next is the issue of baselining, particularly in that first A phase. So how many data points do you have to collect before you can begin treatment? And the answer to that is usually at least 3 data points, and more if you're graphing your data and maybe the first data point was very low and the second is a little bit higher and then it's lower. You just want to keep going until you've established a pattern. If you were counting the frequency of some behavior and the client is at a 2 the first day and 1 the second and 3 the third day, you'd want to get at least another data point, probably more like 2, to make sure that they're not going to go up to 4. All right, so you would not want to see an improving trend there. If you get numbers like 0 one day and 7 the next and 4 after that, and maybe it goes up to 8, your baseline is pretty erratic and you're going to lack control because you're probably not going to be able to demonstrate a treatment effect when you do move on to the B phase. So in that case, you should probably choose a different therapy goal to target for your research study. Another issue is, how do you know when to move from treatment to withdrawal? And as a general rule of thumb, we say that if you see a 30% change in the dependent variable, you can withdraw treatment. And on the flip side, if you've withdrawn treatment, if you see a 30% change, you can then reinstate treatment. So that's how you would know to either withdraw treatment or to reinstate treatment. And along those same lines, another issue that sometimes happens is that we have a stable baseline. We may introduce treatment and the client's performance improves very dramatically. Like, let's say they go from having 40% of the target behavior at baseline to 100% the day that you begin treatment. In this case, even if you only have one data point for treatment in that B phase, you can go ahead and either withdraw treatment if you're using a withdrawal design, or if you're using a multiple baseline design, you can start targeting your second behavior or participant or setting. And finally, we've been talking a fair amount about graphs where the targeted behavior increases, like accurate production of a sound. You can certainly also record your data in terms of decreasing a negative behavior, whether that's disruptive behaviors or stuttering, if you want to frame stuttering as a negative or undesirable behavior. It may be something like throat clearing for a voice client, or the number of instances of pocketing for a dysphagia patient, and so forth. So your baseline can start out either very high or very low, just depending on how you're framing your dependent variable. You can choose how to record your data. For example, you can give percentages, you could do frequency counts, you could do rating scales, and so forth. It's just easier in a lot of ways if you can come up with a single measure for a target behavior or behaviors. So think very carefully about how you will collect and present your data. The last point I want to make is that if you read in the literature, if you read other research books, you're going to find that there are a lot more types of single subject designs than I've presented here. So keep in mind that these are some options. These are perhaps the easiest options for beginners. But when you read articles, you will see single subject designs that are much more complicated, or they're different from what we presented here. And that's all fine, but I just wanted you to know the basics.